So welcome everyone. My name is Margareta Brandt. I am the Assistant Deputy Director for Health System Performance here at the Office of Healthcare Affordability. Thanks for joining us today. This is our 20th meeting of the OHCA Investment and Payment Work Group and our 8th meeting focused on behavioral health investment. Thanks so much for joining us. And if you could start by introducing yourself with your name and your organization in the chat, that would be wonderful. And so I'll move us to our next agenda slide. So today we'll start with an overview of the feedback we've heard in recent meetings on defining behavioral health spending and some discussion of the investment benchmark. And then we'll continue our discussion on the proposed approach for measuring non-claims behavioral health spending that we briefly started last month. And then next we'll look at the behavioral health and primary care module. And if time allows, we'll continue our discussion of the behavioral health investment benchmark and have some structural discussions about how to structure the investment benchmark. And then, of course, before we adjourn, we'll do a quick preview of our March meeting. And as just a brief recap of the meeting format, as a reminder, we appreciate all of your comments in the chat. So you feel free throughout the work group meeting to include comments in the chat. And as just a reminder that work group members, we encourage you all to participate and give verbal feedback and just contribute to this discussion and then make comments in the chat, of course, and then non-work group members, of course, may offer feedback in the chat or provide OHCA written feedback after the meeting. And if possible, we request that you provide your name and organization affiliation with your comments. And just a note that we're not always able to respond or react to all the chats in the meeting, but we use them to inform our work moving forward. And then this is just a quick reminder of our investment and payment work group members and the range of stakeholder perspectives that they represent. And today we wanted to welcome a new work group member. Wynetta Kingsford is the Senior Director of Provider Delivery Systems for the Kaiser Foundation Health Plan and will be filling in for Rhonda Chabran, who was joining us from Kaiser. So Wynetta, if you're on the line, would love for you to introduce yourself. And of course, please correct me if I mispronounced your name.
No worries, I answer to anything close. My name is Wynetta Kingsford, Senior Director, Provider Delivery Systems, as noted, for Kaiser Foundation Health Plan, replacing Rhonda. So happy to participate and look forward to being involved in these discussions. Thank you.
Wonderful, thank you. So next, on our, just before we get into our main agenda items today, we wanted to summarize some of the feedback we've heard from recent meetings about our work, about the behavioral health investment benchmark from the advisory committee and from the work group and from board meetings. So in January, we presented to the advisory committee about the benchmark framework, and this slide summarizes some of the feedback we received from the OHCA advisory committee. So first, several committee members expressed support for the proposed benchmark structure, while one member supported including inpatient spending in the benchmark. So as a reminder, for our proposed benchmark structure is to be more focused on outpatient and community-based services while measuring broadly total behavioral health spend. So that was feedback specifically on that proposed structure. And then we also heard interest in linking the benchmark to benchmark performance to outcomes and measuring continuity of care to ensure that the goals of the benchmark are being met. And then we heard mixed feedback on telehealth. So several committee members highlighted the importance of telehealth as an access point and shared concerns regarding challenges of ensuring high quality and equitable access to care via telehealth. And this discussion resulted in a suggestion to exclude artificial intelligence, specifically chatbot care, from the benchmark. So that's a brief summary of the discussion and the feedback we heard from the OHCA Advisory Committee in January. And then just moving on to a summary of what we've heard, to try to summarize what we've heard in recent meetings from the work group. So, of course, members have raised some technical questions about, for example, whether a primary care visit at which a behavioral health screening was done would be counted as behavioral health spend. Members also pointed out that there are non-claims payments methods in use or envisioned to be used soon. In addition to those that we presented last month, that would count towards behavioral health spending. And one example is episode-based payments. So today we are working towards addressing those questions and providing updates to you all based on how some work we've done and some more thinking that we've done about those and at future meetings. And overall, we have heard strong work group support for the benchmark structure, with a few members raising questions or concerns that the structure excludes inpatient long-term care and residential settings. And then there was also interest or appreciation expressed for the part of the measurement approach that includes screenings and assessments in the spend measurement, regardless of the diagnosis or outcome. And then lastly, some members have asked questions about how our measurement approach and our measurement definitions align with parity law requirements. So we'd like to spend a few minutes taking a closer look at that on our next slide. So at some of our earlier meetings, we reviewed how our work aligned with recent state legislation concerning behavioral health services, such as one law, SB 855, updating state mental health and substance use disorder parity statute. And that law requires health plans to cover all medically necessary treatment of behavioral health conditions, with one criteria of medically necessary being that it is in accordance with generally accepted standards of mental health and substance use disorder care. And then also the final federal rule similarly lays out requirements for how health plans must provide coverage for behavioral health benefits. And in this case, though, the rule expands the scope of what constitutes a behavioral health benefit to include any services that are related to an individual's mental health or substance use disorder. So in practice, this creates a very broad scope for what constitutes behavioral health treatment. For example, a physical therapy visit provided to a person with autism would be classified as a behavioral health benefit under the rule. Another example, treatment by a dermatologist for a skin picking disorder, which is classified as a mental health condition, is also considered behavioral health care under the rule. So, in thinking about this, we thought it would be useful to compare the use cases for the definition of behavioral health under parity laws with OHCA's use cases and think through that with you all. So thinking about the parity laws use case is really focused on supporting equitable coverage with the purpose of ensuring that behavioral health services are covered under the same terms and conditions as medical services. And our use case for measurement and benchmarking is a bit different. And the definitions OHCA is proposing to use are meant to be for measurement and reporting and to promote sustained system-wide investment in behavioral health care and behavioral health services and really support the goals of improved behavioral outcomes. Our overall thinking, and we want to get your feedback on this, is that it seems that aligning OHCA's definition of behavioral health spending with the federal parity rule could substantially increase the level of measured spending that we collect through the behavioral health spending definition. And while alignment may have some merit, it could also undermine OHCA's mandate and goals by distorting the picture of the behavioral health system, provider networks, and access needs. So here we wanted to pause for discussion and reaction to hear your thoughts on, how we should think about the intersection of measuring behavioral health spend and the parity laws. So I'll open up for questions and discussion. Yes, Waynetta, go ahead.
And forgive me, I'm new, so if this makes no sense, just feel free to tell me that. But I'm thinking, so my area of expertise kind of lies in the network space. And so, you know, I see, and they're not bad things, but they could be contraindicated with some of the savings goals of OCA. And that is, at the end of 2023, DMHC established behavioral health provider ratios that are in excess of the requirements for primary care physicians. It's one full-time equivalent non-physician mental health provider for every 1,000 enrollees. And I fairly confident that that's has required and will continue to require plans to be adding to their network, which is difficult to start with given some of the shortage of the providers, but I could definitely see that being a cost impact.
Thank you for raising that consideration. Um, and I think we're happy that I don't think that has been brought up in our work group meetings before, but we're happy to follow up with the DMHC to discuss that further and welcome any other thoughts from work group members. I see another hand raised. Go ahead.
It's Vicky Mays.
Oh, hi, Vicki.
Hi, everyone. Um, I'm struggling a little bit with this because there's a lot of definitions about what we mean in terms of parity and the extent to which we're there. And in behavioral health, we don't seem to even get close to health parity. So what I'm wondering is if there's a model that will go through and can talk about the different places where we're having difficulty meeting that parity. So, for example, in the health plans, everyone will be told that, they have access to and it meets the requirements, and then it turns out there's no availability. You're on wait list 5 and 6 months. You're told you have a mental health benefit until you realize that you need to assess it with your child. So we have a lot of adult providers, but finding child providers. So it seems to me the parity question is not just do we have the structure, but is the structure meeting the needs in the same way in physical health? In physical health, if my child had a problem, there's going to be a children's hospital even, or a children's clinic, but we're not finding the same flexibility around the services needed for behavioral health. And to me, that's not parity then.
Thanks, Vicki. That's a really good flag and consideration. I guess for OHCA's purposes of measuring behavioral health spending, do you have a recommendation or thoughts on whether, we look to align with the parity rules, whether or not they are having the impact that we intend that they have, or think about approaching the behavioral health spend measurement differently?
I would say that we need to kind of uh, take some California data and try and model what are the needs and then what are we seeing.
Hmm.
And then try and figure out, if you use the same model in terms of physical health, you'll see they're probably doing better at, providing the services based on the projected needs. And the question would be in behavioral health, are we doing at least something is equal? I don't think I have a perfect solution, but I do
Hmm.
have a comparative solution.
Okay. We can look into that, Vicky. Thank you for that suggestion, and think about how to bring that back to the work group. Do any other work group members have thoughts or reactions to the intersection with parity laws of our work measuring behavioral health spending?
Margareta, there's a few comments in the chat that may be helpful to elevate to the group from Katrina, and then a few folks building off of Katrina's comment.
Thanks, Mary Jo. Yeah, so it looks like Katrina agrees with the distinction between the purpose of parity and OHCA's goals for measuring and benchmark, and agrees with the concern about potentially overinflating measurement before accurately understanding where we're spending on behavioral health. And Jeff from THCS agrees with that. And I think, and then Sarah has noted that given that networks are narrow in behavioral health, we could encourage both an increase in out-of-network care and increasing therapists on the panels. And yes, Sarah, I think under SB 855 that out-of-network coverage is required if in-network coverage is not available. And then we have another support for Katrina's comment, so thank you, Yagnesh. And I think, Sarah, for our approach to the behavioral health investment benchmark, our proposed approach is really focused on increasing in-network care. And so thinking about how we can complement SB 855 through the proposed approach to the behavioral health investment benchmark by really making sure folks have access to in-network care when needed, and thinking about the affordability aspect of that. Okay, so I appreciate folks chiming in the chat and weighing in there, and thank you, Vicky and Juanetta, for raising those considerations as well. And we can continue this discussion. We can follow up on this in future work group meetings as well. So we'll move to our next agenda item, our first main agenda item, and I'll turn it over to Debbie to continue our discussion from last month on measuring non-claims behavioral health spending. And we'll pause at the end for discussion.
Thanks, Margareta, and good morning. I'm Debbie Lindis, manager for the Healthcare Delivery System Group at the Office of Healthcare Affordability, and I use she, her pronouns. As Margareta said, during today's meeting, we'll focus on capturing non-claims spending for behavioral health and on defining the behavioral health and primary care module, those second and third modules that you see in this diagram. And so first, we'll continue our discussion of non-claims payments. Non-claims payments that are often related to alternative payment models can take a number of forms. And what they all share is that they do not have a provider claim to identify behavioral health spending using diagnosis, service, and care setting. So here on this slide, you see the Milbank principles for behavioral health non-claims data, which serve as our starting point for building OHCA's methodology. First, Milbank recommends collecting data via the expanded non-claims payments framework. This principle aligns with OHCA's approach to collecting primary care non-claims data and alternative payment model data. And we'll review the expanded framework in just a moment. Based on that expanded framework, Milbank recommends including all behavioral health specific non-claims subcategories. For professional and global capitation payments and payments to integrated comprehensive payment and delivery systems, Milbank recommends apportioning payments to behavioral health using encounter data. And this approach aligns with OHCA's approach to apportioning these payments to primary care. OHCA would like to discuss whether it should include portions of other payer investments in behavioral health that are made to providers. For example, payments in support of practice transformation or electronic health record and health information technology infrastructure, similar to its approach for primary care. And now I will turn it over to Mary Jo to walk us through the various types of non-claims payments.
Thank you, Debbie. Good morning, everyone. My name is Mary Jo Condon. I'm a principal consultant with Friedman Healthcare, and I use she, her pronouns. On the next two slides, we're going to review the expanded framework subcategories that OHCA is proposing to include in its non-claims behavioral health spend measurement. You'll note that there are subcategories highlighted in green. Those are the ones for which OHCA recommends including all of the payments in the category in its measurement. On the next slide, you'll see some highlighted in orange. Those are the subcategories that OHCA recommends including a portion of the payments. And here you'll see a couple highlighted in blue. Those are the categories that we're going to have some more discussion on in just a few minutes. You'll note that OHCA recommends including all of the payments in subcategory A2, primary care and behavioral health integration. These payments would also be included in the behavioral health and primary care module. Portions of payments for practice transformation and for data and systems infrastructure might be included to the extent that those payments are related to behavioral health care. For subcategories A5 and A4, those ones are highlighted in blue, because as I mentioned, we're going to discuss a potential approach to that in just a few minutes on an upcoming slide. And we've also added green highlights to subcategories B1, B2, C3, and C4 since our last meeting. This is because we've heard from some stakeholders and other work group members that performance incentive payments, as shown in category B, and episode-based shared savings payments, as shown in category C, are either now in use for behavioral health or in development. So going now to our next slide, for category D, capitation and full risk payments, OHCA recommends including all behavioral health capitation payments, that's D4, and including a portion of professional capitation payments, global capitation payments, and payments to integrated comprehensive payment and delivery systems. In a few minutes, we're going to look at some potential approaches to allocating portions of those payments to behavioral health care. Before we review those draft recommendations, I wanted to take a minute to walk through some of the challenges of non-claims payments. So for starters, the high percentage of professional and global capitation in California increases the need to accurately capture non-claims payments. For states with lower percentages of capitation, it may be less of a priority. While it is important for California to accurately capture non-claims payments, there is no standard method among states for allocating non-claims to behavioral health care. We should also remember that given the data sources, it's not really possible to capture all non-claims payments that go to behavioral health care and to exclude all payments that are not for behavioral health. Most non-claims payments cannot be tied to a specific provider nor to specific service, let alone behavioral health care services specifically. So that means that any method will result in some overcounting and some undercounting of spending on behavioral health services. Now we will review OHCA's draft recommendations for each of the subcategories. So beginning with subcategory A2 payments, these are primary care and behavioral health integration payments. And these are behavioral health spending by definition. So OHCA proposes to include all non-claims payments in this category as behavioral health payments. For subcategories A4, practice transformation payments, and A5, EHR and HIT infrastructure payments, OHCA proposes taking the same approach as how payers will allocate these subcategories to primary care spend. So this would mean that a portion of non-claims payments in these subcategories would be counted when they are paid to behavioral health care providers and organizations. For primary care, that portion is capped at 1% of total medical expense. OHCA is considering a similar limit for behavioral health spend, but we'll get your feedback on that in just a few moments. Now moving on to category B. So these are performance payments. Like we pay for, this is going to be a similar approach also to how we allocate these payments in primary care. So pay for performance, pay for reporting, all of these bonus payments, OHCA proposes that non-claims payments in this category are allocated to behavioral health when they are paid to behavioral health care providers and organizations. For multi-specialty practices and health systems, payers would identify any behavioral health programs that they support and allocate only the payments associated with those programs. For subcategories C3 and C4, these are those condition-related episode-based payments that have shared savings. OHCA proposes to include the shared savings associated with these episode-based payments when the condition is a behavioral health condition, and then last, category D, capitation and full risk payments. OHCA proposes allocating all behavioral health capitation to behavioral health, and that for other capitation payments, data submitters would calculate a fee-for-service equivalent based on a fee schedule for behavioral healthcare services and the numbers of encounters. And I'm going to show you that equation here next. So for workgroup members who participated in the primary care work, this equation may look familiar to you. It mirrors the approach to apportioning professional and global capitation payments to primary care that OHCA developed in collaboration with payers, the workgroup, the advisory committee, and the board. So essentially taking that same approach that we use to primary care and now seeing it applied to behavioral health. For this example, this is an example of a professional capitation payment. Data submitters would calculate a ratio of fee-for-service equivalents for behavioral health care services to fee-for-service equivalents for all services in the capitation. Then that ratio would be multiplied by the capitation amount. As a reminder, these data will come from payers, not directly from the provider organizations that ultimately decide how to allocate capitation dollars. So as I mentioned before, this is just another estimate. The formula serves as, we hope, a best estimate, but it's not a precise measure of capitation dollars spent on behavioral health care. All right, so I want to just walk through a few examples of how behavioral health spend measurement would work for different types of capitation. In this example, the payer uses 4 different types of capitation arrangements. The first type is a capitation payment explicitly for behavioral health services. So the entirety of that payment, in this case, $100 million, would be measured as behavioral health spend. For the next 2 types, professional and global capitation, the payer would apply the formula we just reviewed to allocate a portion of the capitation payment to behavioral health care. In the professional capitation example, the ratio of the fee-for-service equivalent encounters for behavioral health to all encounters results in $5 million of the total $250 million in capitation payments. So The total amount of the capitation payments, $250 million. The amount associated with behavioral health care, $5 million. $5 million is counted as behavioral health spend. For the global capitation example, application of the formula results in apportioning $10 million of the $1 billion in capitation payments to behavioral health. And finally, as with the primary care non-claims approach, none of the facility capitation payments would be apportioned to behavioral health care. All right, now we'd like to pause for some discussion. We would appreciate your feedback on the proposed expanded framework subcategories that would count towards behavioral health spend and the recommendations for specific approaches to identifying non-claims behavioral health spending for each subcategory, as well as the methodology to apportion capitation payments to behavioral health. Also, given that the primary care definition limits the portion of practice transformation payments and electronic health record and HIT infrastructure payments that can be allocated to primary care, let us know if you think OHCA should take a similar approach for behavioral health. And I know this is already occurring in the chat, which is great, but let us know if there are other categories of clinical behavioral health spending that we should consider. All right, I'll open it up to discussion.
Thanks, Mary
Hi,
Jo.
Mary
And
Jo.
Nicole, go ahead.
Hi. Hi, everybody. It's Nicole Stelter from Blue Shield of California. I think I missed it, but I know at one point we had kicked around the idea as well of so it's kind of in the vein of the EHR infrastructure, the idea of spend on prevention and more of the upstream things that any of us are doing. So kind of subclinical, not necessarily in our fee schedules and CPT codes and that, but are about prevention and early intervention. I don't know if maybe that fell out of some of us, but I know there are many of us that are including that in well-being programming, wellness programming. I think they're probably, again, similar to the EHR and infrastructure, probably has to be a cap or a ceiling on how much that might count towards what we're including in the overall. But I'm wondering if we could maybe revisit that.
Nicole, can I ask a clarification on those payments?
Yeah.
So are those payments made to providers or are they made to others? If you could just tell us more about sort of the logistics of the payment, how the money
Sure.
moves and who it goes to.
Yeah, sure. So I'm thinking of so I can tell you how I've seen it and then how we're doing it. It may either be a PMPM to a vendor where they are then passing that through to non-clinical staff that are either certified as coaches, wellness coaches, I'm trying to think of another example. Any of the mindfulness trainings we're doing, some of that's self-serve too, right? So and again, not meant to replace or be clinical as much as upstream what we want to make available to members to do as a form of kind of ongoing emotional well-being, right? And especially if we're trying to reinforce as broad of a spectrum as we can without undermining that we want to make sure to reinforce that clinical is available at levels of care that are needed whenever it's needed. I think it would be important to have at least some registry of that. Did I answer your question, Mary Jo?
Yes, that's really helpful.
Okay.
Part of the reason for my question is just thinking about how that data would be captured, and sort of who the dollars are going to in the system.
Yeah, that would be, yeah, I think the easiest, and I'd have to think through to make sure I'm not oversimplifying, but it would be a vendor. So.
Thank you. That's helpful. It looks like Carrie has her hand up.
Yeah, I just I really appreciated the question, Nicole's question, and I think it also kind of makes me wonder, because I know we did a similar exercise when we talked about primary care, and to what extent we decided to measure interventions to deal with the social factors that impact health, and how we're thinking about and including those. So I do feel like it's it could be a helpful conversation just to understand, like how we're thinking about on the primary care versus behavioral health side, if we are, and whether we should be thinking about that at a certain level. And I just, along with that conversation, I think one of the things that we've been looking at and really interested in seeing more, more of an acknowledgement of is the impact or the critical intervention of community-defined evidence practices, which, like Nicole's talking about mindfulness and meditation and things like that, but there's also, I think, a body of research that's looking at culturally and linguistically responsive interventions, and I sort of see those as complementary to what to the types of things that Nicole is raising, and would love to see some of that, if it can be, or at least a conversation about how we might capture some of that. And I'll share our brief on that topic, but I just wanted to add that point, if that can be helpful.
Thanks, Carrie. And yes, please do share that brief. Vicki.
I have some similar thoughts to what were just being expressed. And if we're really going to think about trying to be lockstep with the changes that we want to see in the healthcare system, then, we all recognize that when it comes to mental health, that we provide treatments of various sorts to people who don't even have a mental health diagnosis. So sometimes we get very strict in terms of, what it is that we're talking about, but yet we're trying to do kind of these wellness things. So big example right now is those of us who live in LA. We are very clear about the wildfire. And so we've launched a series of mindfulness and meditation for 10 straight days for the students to kind of prepare them to be able to take their finals, so that they, we can help them reduce stress, clear thinking, be present. And I'm wondering, at what point are we going to be able to understand that those are parts of things on the continuum? It's like your provider tells you to go and have an aspirin, and then over here your provider has to prescribe a drug. But the time we pay for their time to be able to do that. So I'm just raising this new way of thinking about when we get in the behavioral health arena of the things that we're going to see more of, but we need to have them in a category where there's some revenue.
Thank you. I am seeing possibly another hand up, but having trouble finding that person in the chat. So please feel free to go ahead and speak.
Oh, I think it was someone in the waiting room.
Thank you, Julia. All right. Seeing no other hands up, turn it back over.
Mary Jo, just before we move on, it sounds like folks are interested in OHCA thinking through how to potentially capture, I guess, other types of non-claims payments that may not be included on the expanded framework and may not be paid to providers directly. They may be, paid to vendors, or they may be other payments or spending by by payers. So I guess I just wanted to confirm that that would be kind of a variation or a difference from how we've approached primary care and measuring primary care non-claim spending, which was really focused on measuring payments to providers. And so this, just flagging that this would be, and maybe it's applicable, but this would be quite a different approach of measuring, spending on vendors, or measuring spending on wellness programs or other types of programs that are broader, and not specifically payments to providers. So I just wanted to flag that and confirm that, at least for folks that have weighed in, that is something you're interested in continuing to explore.
Yes,
And I
this
think,
is, yeah,
mhm.
I have my hand up. I was just going to say that's exactly it, because I think otherwise what we're doing is capturing what we do, but we're not capturing what it cost us to do what we need to do. And so some of this is finding its way into primary care. It isn't necessarily there now, but in some of our facilities, you will see that we will have the education department doing mindfulness. We will have, but it's getting, told to the patient through the primary care provider, and the system is doing it, to kind of keep down cost for behavioral health care. So even if it's just a small, like little model of doing it, I think looking at it would be useful.
Um, Thank you, Vicki. And I just wanted to emphasize before we move on that I think the challenge that we'll have, and we can think about this more and come back to this, is that there will be payments or spending by payers on these, like, maybe broad behavioral health initiatives or wellness approaches, but then there's also tons of spending outside of the payer system that we will not be able to capture. So I just wanted to kind of make that clear, that we recognize that there's a lot of behavioral health system outside of, health plans and payers spending on behavioral health initiatives. So we'll continue to think about how to best capture this spending by payers. And then, just to answer Jody's question real quick, whether mobile and street behavioral health services are captured or fall outside of this framework. And Jody, those would, we aim to capture those if they are paid, by the health plan, and either through, excuse me, claims or non-claims payments. And I see Catherine has her hand up.
Hi, Catherine Tier, California Healthcare Foundation. Sorry to be off camera. Newish topic. Can we go back, Mary Jo, to the apportionment methodology? My question was, I was looking back to all the data we don't have that makes this so hard. Can you walk through, given that so on this slide, can you walk through how we get, or how close we can get to getting these kinds of numbers in order to do this math? I understand the formula, but just am unclear on, can we figure out what the number of behavioral health encounters is? Thanks.
Sure. Great question, Catherine. So data submitters, so essentially the payers, have told us that they do have this information. They do have information on the number of behavioral health encounters and the fee-for-service equivalent fees. We appreciate that information may not always be perfectly complete, but we have heard, some relative confidence from our payers and data submitters that they can provide this information. I think the bigger challenge sometimes, and then of course the capitation payment is known. I think sometimes the bigger challenge is that not every encounter generates an encounter. So that's something that we'll have to recognize. And also that how dollars come into the system are not always exactly the same way that they're spent. So, one of the cautions that we gave here is that this data is coming from the payers who are our data submitters. This is what they intended the payment to be for, but the data is not coming from providers. And so there may have been more money that was spent on behavioral health services or less money spent on behavioral health services. Those decisions made within the provider organization, we will not have insight into. It will be based on what the payer intended the dollars to be paid for.
Thanks.
Amy?
Mary Jo, can you hear me?
Yes.
Hi. I just had a clarification question on, I think it was a couple of slides above that, regarding the care management. What if the care management involves behavioral health coordination of care? Is that going to get included in the non-claims?
That's a great question. That's like, a great question. Yeah. Go ahead, please.
Oh, no. I was just going to say it was on one of the ones where you have the blue and the orange.
Sure. Maybe if we go back, I think it's 2 slides or 3. Sorry, forgot about that one.
Yeah,
right
one
here.
more. Yeah.
Yep. So here, I think your question is whether or not, essentially, whether or not A1 should be marked as orange.
Yes.
And, those dollars would be counted as primary care. And there's also the primary care and behavioral health integration category. And so I think what might be tricky, but, obviously welcome the work group's feedback, is trying to figure out what portion of a care management payment was just for behavioral health. Oftentimes, as you know, many individuals with multiple chronic conditions or other medical needs also have behavioral health needs. And so a portion of their care management is around coordinating those behavioral health needs. But that can really vary by the person and by the capabilities and sort of workflows of the provider organization. So trying to sort of pinpoint in a standardized way how to apportion that, I think, might be challenging, but would welcome the work group's input on how we might do that, or whether or not you think working through that should be a priority.
Maybe if we could better define behavioral health, the A2, because I agree with you, right? Kind of parsing that out and teasing that out may be challenging. But add some more definitive specificity to it to include behavioral health care management or something along those lines. I just wouldn't want, the behavioral health space to think that they wouldn't get compensated for their time as they coordinate care between physical and behavioral health. Because it's a very big gap that we in primary care have to fill.
Thanks. Thanks, Amy. I think we can follow up on that. And I guess one thought I have is just, and it's a question to the payers, and are happy to follow up, is whether payers are paying behavioral health providers care management or care coordination fees. Are you paying your behavioral health contracted providers a, per member per month care management fee? So I guess that would be my question, like, do those, and if they don't exist now, like, do payers plan to implement them in the future to pay behavioral health providers like a PMPM for care management? So I think we would welcome thoughts or reactions from payers currently, but we can also follow up on on that. So I think what we're trying to capture and recognize that this may evolve over time is the types of non-claims payments that payers are currently using to pay behavioral health providers, and how those are being used, and how non-claims payments are being used in relationship in contract with behavioral health providers. So would be interested to know if those exist today. So thanks for that flag, Amy. And I guess just before we move on, do folks have any other questions or reactions to the proposed, at least at a high level, the proposed approach to measuring non-claims payments? Any other questions that we haven't, or discussion items we haven't covered yet? Vicky, yes, go ahead.
Yeah, I wanted to rate, looking at the expanded framework, and it came up before and I just didn't. Social care integration, how are you defining that? Because some of that is sometimes has an overlap with behavioral.
Sure. So we can share a link to the definitions of all of the expanded framework categories and subcategories. But let me just, for social care integration, it is, prospective non-claims payments paid to healthcare providers or organizations to support screening for health-related social needs, connections to social services, or other interventions to address patient social needs.
Because one of the things, there's a great study, and I'm happy to share it, that the Harvard people did, looking at this issue of, in primary care, we have platforms. We use those platforms to push people out to social care integration. But there was a feedback loop between pushing them into certain kinds of care, social care interventions that then improve their mental health. So it's kind of like they want to continue to use those particular things to make sure that they improve the mental health, because the mental health then also had good outcomes in terms of physical health. So it's like, a person's all stressed out about
I
being.
schedule this with the county and I pay for it. And they come pay. But if you have something to throw on top, throw it on top, man.
Okay, I appreciate it.
You live here?
Sorry. Go ahead, Vicky.
Yeah. And so it was like, for example, the ability to pay their energy bill significantly lowered their stresses, and they were able to do much better in terms of focusing on their physical health. They saw this as a mental health intervention to some extent, though it's it would be in your definition under social care. And it seems to be what we're doing in terms of pushing out these platforms, these tech platforms for referrals. So um, I just am, there's just ways in which what we're doing is the difference between like pure mental health versus behavioral health, particularly if the behavioral health side is really about kind of the soft pre-diagnosis categories that we all know have an impact in terms of well-being and health. So I guess this is what I keep trying to get a sense of, if those are going to be embraced, or if we're kind of trying to stay away from it.
No, I mean, I don't think we're trying to stay away from it. I think it's just a question of how do we best capture that type of spend, and where does it get organized in the sense of, OHCA's task of measuring primary care spending and measuring behavioral health spending as a portion of total medical expense, and thinking through like how much of that spend should be counted or allocated to behavioral health or to primary care. So it not that we're steering away from the approach to social care integration. We very much want to incentivize and encourage that, but it's just a a challenge or a question of how to best capture that and allocate it in the sense of our work of measuring behavioral health spend. So it sounds like we have some more thinking to do for the care management subcategory and the social care integration subcategory, and we can think about those more. So yeah, so I think there's some good questions in the chat, but maybe for the sake of time, we'll move to our yet another complicated discussion of our measurement of behavioral health in primary care. So I'll turn it back over to Debbie and Mary Jo.
Yeah, thanks everyone for all that feedback. And this is a great segue to discussing our behavioral health in primary care module. So a quick reminder here that these are our 3 modules for behavioral health spending measurement. We've covered care paid via claims in previous meetings, and we just had a great discussion about care paid via non-claims. So now we'll start discussing the behavioral health and primary care module. So OHCA defined this module with input from this work group as part of our primary care workstream last year. And today we have a proposal for a potential modification of the module to support OHCA's use cases. So creating a behavioral health and primary care module has 2 main use cases. First, it allows OHCA to calculate combined behavioral health and primary care spend without double counting. And second, the module allows us to separately identify spending for behavioral health care that's provided in a primary care setting, which can support further integration of behavioral health and primary care, which is an important and desirable outcome. So the spending in this module is also considered primary care, but if OHCA counted it only as primary care and not as behavioral health, we would significantly undercount the total spending on behavioral health services and also distort our understanding of where behavioral health services are provided. And we also want to note that data limitations do limit the precision of this calculation, and we'll discuss that more in a few minutes. So diving into the details here, to identify behavioral health spend in primary care, we would start by identifying behavioral health spending that falls within the current OHCA primary care definition based on primary care provider taxonomies and place of service codes. So this would include CPT codes that are clearly and always behavioral health, such as mental health and substance use screening and integrated behavioral health services. It would also include office visits, case management, and other services that would be considered behavioral health services when the primary diagnosis is a behavioral health condition. So we're calling these sometimes behavioral health primary care services. And then the module would also include non-claims payments for primary care and behavioral health integration. And in addition, a share of capitation payments would be included by applying the capitation allocation formula we looked at a few slides back. And in this case, encounters with behavioral health and primary care codes would be used in the formula. So the second step to this approach is to expand the list of primary care provider taxonomies to include certain behavioral health professionals like psychologists, social workers, and marriage and family therapists. This would allow us to capture the services those providers deliver with primary care codes, such as integrated behavioral health services, screening, assessment, and limited brief behavioral health interventions. By expanding the primary care taxonomy list, these services, when accompanied by a behavioral health primary diagnosis, would be counted as both primary care and behavioral health and thus be part of this module. So there are pros and cons to expanding the primary care provider list to capture behavioral health in primary care spending as we're proposing here. On the pro side, Expanding the list would enable OHCA to capture integrated behavioral health spending for coordination services that behavioral health professionals provide, in addition to integration spending by our core set of primary care providers. It would also make the definition of providers consistent for the primary care spending modules and the behavioral health and primary care module, which is necessary for a mutually exclusive, collectively exhaustive approach to counting spending. And compared to doing a separate data collection to capture this integrated behavioral health spend, the proposed approach would impose less of a burden for data submitters. So some reasons not to expand the provider list are, first, that it might result in capturing some spending that shouldn't be part of the module, such as services that are included in the primary care code set but are not delivered in an integrated setting. Also, data limitations would mean that certain behavioral health services, such as psychotherapy, would not be included in the behavioral health and primary care module, even when they occur in an integrated primary care setting. And finally, the expansion would alter the primary care definition that data submitters are currently using. So we will look forward to hearing your thoughts and questions on these trade-offs in a few minutes. And first, I'll hand it back to Mary Jo to review the rest of this section.
Thank you, Debbie. All right, so this is a visualization of the behavioral health and primary care module. The green box at the intersection of the two larger rectangles is the module. The spending in the green box would be part of both behavioral health spend and primary care spend. However, when adding up these components of total medical expenditures, the module would be subtracted so that it's not counted twice. And you can see that equation at the bottom. The recommended approach maintains a focused primary care definition with a few minimal changes. The expanded primary care provider list would increase the level of primary care spend, but we think for an important purpose, which is to capture more integrated behavioral health spend. At the same time, we estimate it would be likely a minimal increase. The module approach allows for mutually exclusive, collectively exhaustive results. That is, the portion of spending that represents the overlap of behavioral health and primary care is the same for both. So including it in either category does not distort the totals positively or negatively. The module is also consistent with the general approach to behavioral health measurement. And similarly, we think that there will still likely be an undercount of integrated behavioral health care because integration service codes are not always used, and we will not be including codes associated with the therapy provided in an integrated setting. The addition of the taxonomy list of behavioral health professionals who provide integrated care would likely reduce that undercount. So essentially adding those additional taxonomies helps to reduce the undercount, but there's still going to be an undercount because we would not be including the therapy codes. Here's another way to think about why it may be necessary to expand the primary care provider list. So you can imagine a behavioral health provider delivers a service while practicing in an integrated care setting, which is included in the primary care code set. Without the taxonomy expansion, spending for the service would be included in the behavioral health spending module, but not in the primary care module. This creates inconsistency for reporting because the services that would count as behavioral health in primary care from the behavioral health perspective, but would not count as primary care from a primary care perspective. Now we're going to go back to some more discussion. We would appreciate your feedback on any or all of the questions. Should OHCA expand the primary care taxonomy list to include behavioral health providers? Are there use cases on the slide the right use cases for the behavioral health and primary care module. So essentially calculating behavioral health and primary care spending without double counting, and then also calculating the behavioral health spending occurring in the primary care setting. Are there other use cases we should be thinking about? And are there other modifications to the approach that OHCA should consider? We also recognize that this is really complicated to communicate, so we're happy to go back to any of the slides, review them again, or discuss further. And it looks like Nicole has a comment or question.
I think I have a question, and I'm having trouble placing if this fits or not, and tracking, and it is complex. Thanks for taking us through it. It's helpful. For collaborative care, which is, contained specifically to, I think, 4 or 5 different CPT codes, but primary, it is care provided, but not by a behavioral health clinician, but where there's primarily a behavioral health diagnosis. Where would that fit in this then for behavioral health, but not primary? So we would kind of pull those CPT codes out or that kind of care out. How would that work?
Sure. So that would be in the module. So that would be considered behavioral health and primary care spend. So it would be placed, if OHCA were measuring just behavioral health spend, it would count. If OHCA were measuring just primary care spend, it would count. And if OHCA was reporting on what's the behavioral health occurring in primary care, it would count there too. And so essentially having this modular approach allows us to have that spending count in all 3 of those analyses, but also be able to essentially subtract it when needed if we want to measure what's behavioral health spend and primary care spend.
Okay. And how would we account for primary care visits, family visits, pediatrician visits that are maybe medication monitoring or kind of maintenance?
So
where it's not collaborative care, but there's still, I don't know. Yeah.
Great question. So I would think of those services as sometimes BH, right? So, you can have a medication monitoring visit for a variety of different conditions, but in this case, it would be a behavioral health condition. And so provided that there was a behavioral health diagnosis on the claim, even if an internist had that visit, it would still count as both in all 3 of those categories.
And how far down, Mary Jo, how far down a claim are we going to look for a behavioral health diagnosis? Because it could be I could have very well controlled anxiety, but it's all the way down the 10th line of a claim. Is that still okay? So
the current proposed approach is to count the primary diagnosis. Okay. And we recognize that this may also lead to some undercounting, right? Because one of the things that we've heard from providers is that the primary diagnosis is not always the primary reason for the visit, and that sometimes there's a variety of reasons why the behavioral health diagnosis might not be in that primary spot. But because there's also many times when folks have a behavioral health diagnosis in the, let's say, 4th position, but they're there for their diabetes, there's there's this undercount, overcount tension that we're working with.
Okay. Thank you. Appreciate clarification.
Kevin.
Great. As always, Mary Jo, I really appreciate the thoughtfulness that went into this and that you clearly, walk through here's where it may generously count here. In this last example here is where it may miss stuff because it's not the first, listed diagnosis, primary diagnosis. So this stuff is all so hard. I really always need to be totally convinced that adding more to primary care definition is really valid. I think you're convincing me probably in this case, it's a pretty limited edition. let me push. I think the one thing would be site of service, place of service code, right? Because again, if you go back to that, definition, it's that part on the far right that's the new component that we'd be adding to the primary care measurement, correct? Um, and I think it's these new provider taxonomies that we hadn't included, but it's so critical that it's like a psychologist it would have to be in a primary care place of service. Or tell me a little bit, how are we going to distinguish a freestanding psychologist working out of their own office from one who's part of our clinic team at a FQHC or other place?
I wish we could. But the reality is that we really can't. And so that's the reason to not, for example, include those therapy codes. And that's why we're really focused on a minimal set of codes really related to, integrated behavioral health, and also some assessments and screenings, brief interventions. There's actually codes specific to like a 15-minute intervention, for example, by a social worker or a psychologist. So really kind of focusing in on a very limited set of codes that qualify as primary, behavioral health in primary care, and then including the therapy and those other codes as behavioral health spending only.
So I guess then I am, all right, now, based on what you just said, I actually am having a little bit more misgivings because I guess I'd really want to see what those CPT codes are that then would be included. I think maybe it'd be if you could follow up with, just saying, and
Of
not
course.
that I'll know the codes offhand, but like the codes and what they're actually representing in terms of the services, because I think we'd want to. Yeah, it's much more straightforward when they're co-located, right? I'm totally all in on that, like co-located behavioral health services in a primary care setting. I think it is tricky when it's not co-located, so you have a place of service that's an office, but it could again be just a freestanding psychologist, just a clinical psychologist. Okay, you're not going to include the CPT service code for a 45-minute therapy session, it sounds like, but maybe the 15-minute brief intervention. So I guess, I'd love to see, could you follow up with like what CPT codes would be included and what would not be included? Then I
Of course.
think a little more about this. Thanks.
Vicki.
In terms of if you could go back to the slide with the added providers, I think that we might want to think a little bit about lining up with those groups that the state of California is really trying to incentivize to participate in mental health care. So, for example, they have funded nurses to increase the number of psychiatric nurses that are providing care. So you're going to see, I think we're only in wave 2 or 3 of that, but you're going to see more of them, particularly if they're nurse practitioners providing care. The other group, and I don't know enough about this, but in what was called the Mental Health Services Act group, was really tuning up these peer, almost navigators, to be in certain settings where, one I can think of here is Step Up on Second, which is kind of a housing facility for those with mental health. And those peer advisors were actually running some of the sessions that we would call well-being. I'm not sure if I call them mental health, but so we have to think about the fact that the traditional ways we're doing this, the state of California is funding us to be a little more untraditional in terms of the delivery of this. The third area that I wanted to bring up was the school-based clinics. So what you will see is that a federal qualified health center will go working in the community and help establish the school-based clinic. The school-based clinic is under the auspices of the Federally Qualified Health Center and the school. And of course, they're providing a significant amount of mental health care. So I'm just trying to make sure that I think what you've done in covering real traditional ways is great. To think about the way California is doing these breakoffs to provide mental health services is what I would want to see added. And some of this may help us by pulling the CPT codes and realizing that, at Drew here, that you get your health care, and we have what's known as the 21 blocks, and 21 blocks around it were all these things that were put into place to help you do the other services. And again, mental health services are there, but not in a primary care clinic. It might fit that, oh, there's a psychologist in an office over there, but it really is facilitated by the health clinic to say these are the ancillary services we need close by.
Thank you, Vicki. We can continue to dig in to some of those pieces.
And it sounds like it would be helpful for us to share with you all the proposed code set revisions and send that to you all for reaction and future discussion. I'm not sure we can promise it by the March meeting, but either before the March or April meeting, we can put together the code list that would be revisions to the primary care definition and what would be included in the behavioral health and primary care module for you all to review and have something specific to react to. And thanks for folks flagging in the chat, things like the collaborative care CPT codes and how peer partners and wellness coaches may be able to bill. So we can look into some of those flags as well. Before we move to our next agenda item, are there any other questions about or thoughts, reactions to the behavioral health and primary care module? Okay. Well, we will follow up shortly with more details for further discussion. Thank you. Yeah, turning back to Debbie.
Great. So for our final agenda item, which will almost certainly be continued next month, given the short time we have today, we'll come back to our discussion of the behavioral health investment benchmark. A few months ago, we discussed the framework for the benchmark, and we're moving on now to defining the benchmark itself. So you've seen this picture before, showing the distinction between the broader approach to measuring total behavioral health spending, focused approach to setting a behavioral health investment benchmark. The spending to be compared to the benchmark, which is intended to promote specific policy goals, is a subset of the spending included in the overall measurement. So to provide some context, this is an example of a state behavioral health investment benchmark. And in fact, it's the only state benchmark for behavioral health spending that's currently in use. And it's a good example of a focused benchmark. So Rhode Island's been set by the Office of the Health Insurance Commissioner, or OHIC. And the benchmark, which OHIC calls a behavioral health spending obligation, focuses on spending for community-based behavioral health care for fully insured children and adolescents aged 0 to 18 who are covered by commercial carriers. OHIC requires that by 2025, carriers increase their member per month spending on community-based behavioral health care for the target population to 200% of 2022 spending. That benchmark might sound daunting, but not quite as daunting as it sounds, because the targeted spending, community-based care for children and adolescents, is low relative to total healthcare spending and even relative to total behavioral health spending. So for example, if spending at the baseline towards the benchmark were 50 cents per member per month, the benchmark would require commercial payers to increase that to $1 per member per month over 3 years. After 2025, carriers in Rhode Island must have annual expenditures on community-based behavioral health care for the target population at the market average as determined by OHCA. The benchmark will include claims and non-claims spending for the community-based behavioral health care, and it only applies to spending for residents of Rhode Island who receive care from providers located in the state. And if carriers don't reach the benchmark, they'll be subject to penalties determined by the commissioner. So now we'll review 4 questions and OHCA's associated recommendations that we discussed at the November and December workgroup meetings. And we'll introduce 3 additional key considerations for the benchmark, and we'll probably return to those to discuss those in more detail in our next meeting. So the first question asks what the increased behavioral health investment should achieve. Essentially, what's the policy goal for the benchmark? OHCA's proposal is that increased investment should help individuals in need of behavioral health care to receive more timely care in more appropriate settings and with less out-of-pocket spending via improved access to in-network, outpatient, and community-based services. To achieve the benchmark's aims, OHCA is proposing that the benchmark applies to in-network, outpatient, and community-based behavioral health services covered via commercial and Medicare Advantage plans, excluding pharmaceutical spend. In the future, when data collection and methodology allow, OHCA would expand the benchmark to Medi-Cal. This approach focuses new investment on high-value upstream care delivery and services that OHCA wants to incentivize. It also addresses the current lack of in-network access to providers and the resulting consumer cost burden. So returning now to look with more specificity at the relationship between data for measurement of overall behavioral health spending and data for measuring performance against a focused benchmark, this slide shows that the benchmark, represented by that inner light blue circle, might focus on community-based and outpatient care settings, such as outpatient facility and professional care, including primary care and telehealth services, and community-based mobile clinic services. The service categories for the benchmark are a subset of those included for overall measurement. So in addition to those benchmark categories that are highlighted in light blue, the total spend measurement would include categories such as emergency department and observation services, residential services, long-term care, and inpatient services. So OHCA is proposing to focus the benchmark on in-network, outpatient, and community-based behavioral health services. And with the aim of the benchmark, this approach would focus attention on specific high-value behavioral health services which currently have limited access, but which have a high potential to improve outcomes. It would apply to all California commercial and Medicare Advantage members without restrictions on age or geography. And as we've previously discussed, OHCA is exploring some potential supplemental analyses that are listed here on the slide that could support monitoring whether our aim is achieved. So for example, an analysis of trends over time in the proportion of behavioral health services that occur in outpatient and community-based settings would give us insight into how much progress California has made toward improved access to care in those settings. In California, OHCA will be evaluating the feasibility of all of these potential analyses. So as with the primary care workstream, there are some key decisions the work group should consider in establishing a behavioral health investment benchmark. And we'll discuss each of these key decisions. Probably we'll get started reviewing what they are and come back to the subsequent slides and more discussion at our next at our next meeting. So as a preview, those 3 key decisions are: should the benchmark be a percentage of total medical expenses or a per member per month amount? Should the benchmark focus on incremental or long-term improvement, or some combination of those two? And finally, what should be the timeline for achieving the benchmark? And so you'll have the next several slides available for your reference prior to continuation of this discussion at our next meeting. And in the interest of time, I will hand it back to Margareta to wrap us up for today.
Thank you, Debbie. So just as Debbie mentioned, since we weren't able to get to all of our discussion slides on these key decisions, welcome you all to review them as we move forward. And before our next meeting, we'll revisit them and bring your thoughts on how to structure the benchmark to the next meeting. So I'll move us to just a quick next steps wrap up. And just wanted to, as we always do, remind folks where we are in our timeline for our work. So, of course, we will plan to have our monthly meetings in March and through July. And just to note, as we mentioned earlier at the beginning of the meeting, that we presented an overview of the behavioral health workstream to the OHCA Advisory Committee in January. And then we'll present further updates to the advisory committee in March and June. And we will update the OHCA board on our progress at their meeting next week. So we'll be providing a similar presentation as we did to the January advisory committee to the February OHCA board meeting. And then we'll meet and bring proposals and updates to the board again in April and June. And our tentative timeline is to bring a recommended behavioral health investment benchmark to the OHCA board for approval in July. And just as a preview of our next work group meeting, we will, of course, continue our benchmark discussion and develop a more granular definition of defining the benchmark in our next work group meeting in March. And we will continue to work on and think through all of the feedback and discussion we received today on the discussion of behavioral health non-claims payments and the behavioral health in primary care module, and think about whether we focus on that a bit in March or we revisit that discussion in April. So you'll see updates from us on both of those topics as well. And I think with that, we will sign off unless anyone has a question or thought before we sign off. And it looks like there is at least one question in the chat from Catherine about the benchmark measurement related to non-claim spending, and that will be part of our discussion for defining the benchmark, is what from non-claim spending counts towards the behavioral health investment benchmark. So, and I know we had some other questions that we weren't able to maybe address in the chat. If we weren't able to address all of them, we can follow up offline, and happy to address them as well next meeting. So thank you all for the robust discussion today on very complicated topics. We very much appreciate the engagement and hope you all have a wonderful day. And feel free to follow up via email if you have additional thoughts. Thank you so much.
Thank you. Have a good day.